here on the channel where you will have details on posterior anterior view, anterior posterior view, and lateral view. Now, it is very important you know the indications why posterior anterior view are done and what are the features of posterior anterior view. Then anterior posterior view, what are the indications and what are the findings you see, as well as the lateral view. Now, it is very important, and as I mentioned, I will share the link of the previous imaging so that we don't waste too much time in discussing this, so that we'll have chance to go through a lot of slides. But by the way, this posterior anterior view, the patient is standing upright, and of course, the scapula are away from the lung field, and the arms are externally or internally rotated. So the features of posterior anterior view: one, you see the scapula are away from the chest, away from the lung field. This is the scapula because the arms are externally rotated. Okay, because the patient will place his hand over the box that will capture the image. So you will find the arms are internally rotated, carrying the scapula away from the lung field. The clavicle, both clavicles are slanting. Both clavicles are slanting. Okay. Now you have teardrop appearance of the spinal process of the cervical vertebra are clearly visible in posterior anterior view because the X-ray is coming from behind. So you have the spinal process visible as a teardrop appearance. Then the posterior ribs are more prominent. You can see they are more prominent than the anterior ones. The posterior ribs are more prominent. That is another feature. Then you have at least 7 ribs above the diaphragm. This is the diaphragm. Now you have 1, 2, 3, 4, 5, 6, 7. At least 7 ribs above the diaphragm because the X-ray is coming from behind. More of the ribs are exposed. So these are some important features you need to know about posterior anterior view. Scapula away from the lung field, clavicles are slanting, teardrop appearance of the spinal process of the cervical vertebra. Posterior ribs are more prominent, as well as the ribs at least 7 above the diaphragm. So in anterior posterior view, usually it is done in a very sick patient that cannot stand upright. So the X-ray is taken while patient is in supine position. Okay, X-ray is taken while patient is in supine position. So the clavicles will be horizontal. The spinal process of the cervical vertebra will not be prominent, and you'll have less than 7 ribs above the diaphragm in most cases, as well as this, the scapula will be obscuring some part of the lung field. So lateral view, usually, if you see a lateral view, it's used in differentiating patients. In a patient with in cardiomegaly, you want to differentiate if the cause of the cardiomegaly is from pericardial effusion or from the enlarged heart itself. So in lateral view, it will differentiate, because if it is from pericardial effusion, you have obliteration of the space in the retrocardial retrocardiac space between the heart and the vertebra. That space, that I think when you see that, it will demonstrate more. Now, we'll go into some abnormalities, some image abnormalities, but you should also remember there are some certain diseases where you do a chest x-ray, which is a very important, it is a very important investigation for chest diseases. However, there are some certain disease where you even do it, when you do a chest x-ray, it will show a normal finding, even though patient has the disease. So it is important that that not all chest pathology, not all chest pathologies are visible on chest x-ray. Okay, that is very important, because sometimes patients with bronchial asthma, you might see a normal chest x-ray. Okay, normal chest x-ray. You can see that in bronchial asthma. You can see that even in bronchitis. So don't think it is all the time you do chest x-ray for a chest pathology, you will find an abnormality. Patient with bronchiectasis. Now, sometimes patients will even have nodular deposits on the chest, but you won't be able to see those nodules, maybe metastatic deposit to the lung parenchyma. And you do a chest x-ray and that is normal. This is usually seen if these nodules are less than 0.5 millimeters. You will not see anything. You think it's a normal x-ray. Okay. In conditions like endobronchial tuberculosis, you can have a normal x-ray in a patient with endobronchial tuberculosis. Some atypical chest infections like viral pneumonia, mycoplasma pneumonia, allergies, okay, allergic alveolitis. You can have all types of x-ray with abnormalities. So, types of pathologies with abnormalities. But as we mentioned, okay, in a normal chest x-ray, there are some certain areas you need to look at. Now, let us look at that image again of a normal chest x-ray. Now, usually when the hilum, this area is called the hilum, okay? And the hilum of the lungs have lymph nodes, okay? There are lymph nodes, they are normally around, all these are hilar lymphadenopathy. They are normal, but in a diseased patient, disease chest, you might see these becoming significant, and the opacities here will be more marked. The opacities here will be more marked. So it is very important you differentiate. You can see these x-ray, there are just no opacity. It is not marked because it is a normal chest x-ray. Now, we are going to see there are some certain conditions now where you have hilar opacities, which could be unilateral or bilateral. Now, because of your multiple choice questions, you should know chest X-ray with unilateral opacity, okay, hilar lymphadenopathy, or bilateral hilar lymphadenopathy. Okay, chest conditions. I hope you took note of those conditions that gives a normal chest X-ray. These are the conditions. We said there are conditions that can give hilar lymphadenopathy, which could be unilateral or bilateral. Okay. Most of the times, the bilateral are commoner than the unilateral. Okay, because it's more of a systemic problem that will give you bilateral than a pathology affecting one of the lungs, even though systemic problems can also give you a unilateral hilar lymphadenopathy. Okay, so in unilateral, like bronchogenic or bronchogenic carcinoma affecting a particular lung, you might see only that ipsilateral side has a large lymph node, and that is very important, you know. You look at that particular area. If you see a chest X-ray showing a unilateral hilar lymphadenopathy, examine the ipsilateral lung carefully to see if there is a pathology there. You can see it in lymphomas also, even though lymphomas will commonly give bilateral. Okay, there's a condition called sarcoidosis. You have pulmonary embolism. Pulmonary embolism can give you a unilateral hilar lymphadenopathy. Okay, now then for bilateral, commonly tuberculosis. Now, don't forget, aside tuberculosis, sarcoidosis lymphoma can also give you that. I told you lymphoma will even give more of bilateral than unilateral. One important thing about hilar lymphadenopathy, you tend to correlate with the clinical presentation of a patient. Now, you should know not only infectious or infiltrative processes will give you hilar lymphadenopathy. Sometimes patients with pulmonary hypertension, okay? Yes, pulmonary embolism can present with features of bilateral hilar lymphadenopathy. So you should take note of that, okay? Now, on X-rays, again, you should also know about opacities. There are different types. Don't forget, if you look at this X-ray now, this condition, you find that there is something here which we will discuss shortly. But any image that appears white like this is described as radio-opaque. White shadows are called radio-opaque. White dark shadows are described as radiolucent. Okay, white shadows are described as radio-opaque, while dark shadows are described as radiolucent. So when the bones here are radio-opaque, while the lung is radiolucent. So it means when you have air, look at the surrounding. Because there is air here, it appears radiolucent. Okay? So this lung is appearing radiolucent because there is air in it, okay? Now, if you look at this lung and this lung, they are not of the same size. What is happening? Because there's a radio-opaque shadow that has occupied these other parts of the lung field. This radio-opaque could either be heterogeneous or homogeneous. When you say heterogeneous, it means it is non-uniform. When you say homogeneous, it is uniform. Now, if you look at this radio-opaque shadow that has occupied this part of the hemithorax, it is homogeneous, okay? It's uniform. It's when you see a homogeneous opacity, that is fluid, okay? That is fluid. If you see a heterogeneous opacity, it means there's parenchymal involvement. It is infectious involvement of the lung parenchyma. Yes. So now for this image we see here, it is more of a fluid that is occupying this space here. Okay. So that is it. Okay. Now, before going into that, sometimes you should note that when there is a fluid in a space, let's assume this is the lung. Okay. And you know the lung is surrounded by pleural. Okay, there's a pleural around this. Now, there can be accumulation of fluid in this pleural that will obliterate this space. Okay, as it accumulates, it compresses on the lung, and there could be that will cause homogeneous opacity. Now, there could be opacities within the lung parenchyma. Okay, and if these opacities are in the lung parenchyma, they will give heterogeneous. And this is more common in infectious processes as well as malignant deposits on the lungs. Well, however, if it is fluid accumulation, it will give a homogeneous opacity. Now, in terms of opacities, there are some certain things you need to look for. If you see an opacity on an X-ray, one, nature of opacity, whether is heterogeneous or is homogeneous. Two, you look at the mediastinal, okay? So is there mediastinal shift? And this mediastinal shift, one, it could remain unaffected, okay? Unaffected. It could shift to the right or it could shift to the left. So anytime you see opacity on the chest X-ray, You should look at the nature of the opacity. If it is heterogeneous, it's more likely an infectious process affecting the lung parenchyma. Commonly in our environment is tuberculosis. If it is homogeneous, it's more likely to be fluid accumulation in the pleural space. In some conditions, you have combination of both heterogeneous opacities in some part of the lungs and homogeneous opacity. So it's an infectious process or malignant process that has now involved the pleural with accumulation of fluid within the pleural. So anytime there is accumulation of fluid within the pleural, because it is increasing the intrathoracic space, it will exert pressure and shift the mediastinum. Okay? Now, you should know conditions with opacities with no mediastinal shifts. There's no shift of the mediastinum. I told consolidation, like TB or pneumonia, without effusion. Okay? TB, pneumonia without effusion. There will be heterogeneous opacity without mediastinal shift. Two, you might have just small pleural effusion, not large enough to cause shift. Three, you might have conditions like mesothelioma. This can cause no mediastinal shift. Now, you can also have conditions where there is mediastinal shift to the opposite side. That means if you have a pathology on the right side and the mediastinum shifts to the left side, okay? So you have pleural effusion. If you have pleural effusion on the right, the mediastinum shifts to the left. And this pleural effusion is from moderate to large pleural effusion, because if it's small, it will not shift. Now, pneumothorax. When you have air, it shifts the mediastinum to the opposite side. And importantly, again, you need to know about a condition called diaphragmatic hernias. Diaphragmatic hernias, when you have a rent or a defect in the diaphragm and content of the abdomen, maybe stomach or intestine, enters the chest, the thorax, it causes increase in pressure in that hemithorax, which shifts to the opposite side. So we've seen conditions that will cause no mediastinal shifts and conditions that will cause mediastinal shift to the contralateral side. What of conditions that will make mediastinum to shift to the affected side? A disease condition that will make the mediastinum to shift to where the pathology is, usually, commonly, is lung collapse. Lung collapse. When that lung collapses, the pressure on the contralateral lung will be higher and it will shift to the affected side. Okay? Even when you have fibrosis, chronic lung fibrosis. When you have pneumonectomy, surgery, you remove the lungs on that side. Post-pneumonectomy, you will have mediastinum shifting to the affect where the lungs is removed. And sometimes you might have some congenital conditions like pulmonary hypoplasia. So these are very important. You identify all these. Now, sometimes you might see an X-ray where you just have a lung with widespread opacities everywhere. Okay, you just have widespread opacities. Okay, now these opacities can occur in cancers where you see them like cannonballs, just see cannonballs metastasis. Okay, you can see widespread opacities in cancers, carcinomas, tuberculosis. You can see them in pneumonia. Okay, don't forget fat embolism. Fat embolism, and even in pulmonary edema. These are some common conditions where you see widespread opacities. Now, you should also know in some conditions, you may just see cavities. You just see cavities in the lungs, okay? You take a chest x-ray, you just see cavities everywhere. And now, lung cavities, usually in our own environment, when you see cavities, they are common with tuberculosis. But the cavities in tuberculosis, what is peculiar about it, they usually occur in the upper parts of the lung. They usually occur in well-aerated part of the lung, which is the upper part of the lungs. Yes, but there are some other conditions where you can see cavities aside the typical tuberculosis that usually occur in the upper parts of the lungs. Okay, so infection by Staphylococcus aureus will also give cavities. But the difference between this, you see, for TB, they are usually at the upper part of the lungs. But for Staph aureus, usually they are multiple and their walls are thin. They have thinner walls. And for TB, they have thicker walls and they are usually in the apical region. Other conditions aside Staph aureus. Now, know that the first thing you should think of when you see cavities in the lung is tuberculosis. And to buttress your point, look at the upper part of the lungs. Then other conditions that can give you that Staph aureus, Klebsiella pneumonia. Okay. Now in Klebsiella pneumonia, the wall of the cavities are usually irregular. Sorry, for TB, we said they are upper lobe and they are bigger cavities. They are thin line, not thick. They are thinner. Okay. Now you see Klebsiella pneumonia. Now some other disease conditions are hydatid disease. Hydatid disease caused by Echinococcus granulosus. It doesn't affect only the lungs, it can affect the liver. So hydatidis, okay? So don't forget TB number 1, Staph aureus, Klebsiella pneumonia, hydatid cysts. Okay, they can give you cavities. Other conditions will include, not commonly, carcinomas of the bronchus. You can have conditions like bronchogenic cysts. Some patient might just have a congenital cystic lesion. I could remember a patient I saw some few years ago when I was doing my posting in cardiothoracic unit. The patient came with difficulty in breathing, and we did a chest x-ray. It showed us a very huge cystic cavity in the upper part of the chest that is occupying 1/3 of the lung. We now did a CT to give us a better definition. Okay, and ultimately it was found out to be just maybe a congenital something that just, it was not a malignant lesion. So you could have a malignant cystic lesions. Okay, most of the times they are benign. Okay. Now we've talked a lot about X-rays as well as different conditions that you see, the various types of pathology. Now, before we proceed to see all these conditions on this X-ray, let's also briefly talk about okay, let's talk about an important pathology you hardly escape in your exams. This is tension pneumothorax. Tension pneumothorax is an important chest condition that usually follows trauma, either a penetrating chest injury or even blunt chest injury with associated rib fracture. And that fracture rib is causing puncture on the lungs, in such that the injury to the lungs produces a valve effect. You know, when you have a valve effect, valve allows unidirectional flow. Okay, a valve will allow a unidirectional flow of air or fluid. If you have two leaflets like this, okay, if this is a valve on this passage, you see it will allow flow in this direction. Even if there's return of whatsoever is flowing, the valve will cause a recoil. Okay, it will not go back. So that's what the valve effect in tension pneumothorax does. Now, usually when a patient sustains such injury, the affected lungs will tend to collapse gradually because the pleural space of the affected side will be accumulating a lot of air, compressing the lungs and shifting the mediastinal to the contralateral side. Patient will present with chest pain, difficulty in breathing, distended neck veins, sweating, hypotension. They will now go into shock and eventually present with cardiac arrest. Okay, so in tension pneumothorax, let me demonstrate an image for you so that you understand what is really happening in a tension pneumothorax. Okay, this is the lung. This is the pleural. Okay, there is injury to this lung. Now, this injury will now cause air to move out from this lung into the pleural space. And when the air moves into the pleural space, okay, it cannot go back into the lung because these will now serve as the valve. This is now the valve here, okay? At any point where a patient inspires, if they take in air during inspiration, okay? During inspiration, the air moves into the pleural space and build up pressure here. Now, what happens to this lung? The lung size is compressing because of the pressure that is building up in the pleural space. Okay? Now, you will notice this pressure will build so much that the mediastinum will shift to the contralateral side. Okay? Now, if you remember, the diaphragm here, there are openings through which structures communicate the thorax and the abdomen. One of the structures is the inferior vena cava. It has inferior vena cava opening. Now, if the mediastinum is shifting to this contralateral side, of course, this opening will also move and there will be kinking. There will be kink here at this opening. And when there is kink at this opening, the venous return to the heart will be drastically reduced. Patient will have hypotension and, of course, present in shock. Now, the overall features of tension pneumothorax, before we talk about the three classical triad on the X-ray, there are three classical features you need to know on the X-ray of a tension pneumothorax. But before we go that, you should know that they have chest pain, they have difficulty in breathing, they have distended neck veins, sweating profusely, hypotension, they can present in shock, okay? So you have mediastinal shift to the contralateral side. Now, what are the X-ray features you see in a patient with tension pneumothorax? The X-ray features, one, you will have, there is increased intercostal spacing, okay? Increase intercostal spacing. Or, yes, okay? Increase space of the intercostal, okay? Increase spacing of the intercostal spaces of the affected side or lateral side. In other words, if you do an X-ray, one of the things you will see, the ribs will be spaced apart because of you have air is going into that space. So if you compare the space on this side, it will be wider than the space on the contralateral side. That is number one feature when you just look at the ribs. Okay. Number two, there's mediastinal shift. To the contralateral side. Because the pressure is more here, it pushes the mediastinum to the contralateral side. And the third feature is depression of the diaphragm of the affected side. Now, anytime you talk of tension pneumothorax on an X-ray, tension pneumothorax on an X-ray, these are the three features you are looking for. It's the lateral increase in the intercostal spaces, okay, contralateral shift of the mediastinum, and depression of the diaphragm of the affected side. If you go back to this image, because air will be accumulating here, okay, because air will be accumulating, you now have an image that will look like this, okay? If you see the diaphragm will depress on this side, and the diaphragm is at a higher level on this side, okay? Then you have mediastinum. See, mediastinum shifts to this side. Diaphragm is at a lower level, and the ribs are wider apart. So don't forget, these are the three features you see on X-ray. Okay, one, mediastinal shift. Two, widening of intercostal space. Three, depression of diaphragm of the affected side. Okay, okay. If you remember, we talked about opacities, which could be homogeneous or heterogeneous. When it is fluid, it is homogeneous. And this fluid could either be blood, that is pneumothorax. It could be pus, that is empyema, common in tuberculosis. It could be lymphatic fluid, that is chylothorax. Okay. So all in all, they are what? Pleural effusion. In fact, you might just have serous fluid, okay, which could be from infectious causes or from malignant deposit on the pleural. Now, how do you identify that this opacity is fluid on an X-ray? The way you identify that it is fluid, you have three main features. One, meniscus sign. Two, homogeneous opacity. And three, you have obliteration of cardiophrenic and costophrenic angles. Okay. Now we'll go back to the first image so that we'll demonstrate pleural effusion. Okay, let's go back and now identify all those pathologies we are talking about. Okay. Now, to get a clearer image, okay, I need to demonstrate this. Okay. Now, I need to demonstrate it clearer for you so that you appreciate all these three features I mentioned. Okay, let's see it again. Now you can see this, there's a homogeneous opacity on the left side of the chest. This homogeneous opacity. It is uniform. That is number one. So telling you is homogeneous is likely to be a fluid. Then two, there is meniscus sign. Meniscus sign. Meniscus, this is a meniscus sign. If you remember your physics, if you have fluid in a jar, the adhesions between the fluid molecules and the surface, the cohesive force cause a meniscus sign. So this is a meniscus sign. Okay. This is a meniscus, signifying that there is fluid here. So you can see this is a meniscus sign. Now this is number two. And number three, this part is called cardiophrenic angle, and this is called costophrenic angle. Cardiophrenic angle is the angle between the heart and the lung. Costophrenic angle, the angle between the ribs and this angle, the diaphragm and the heart is cardiophrenic. Between the ribs and the diaphragm is costophrenic angle. Now, you can see here there is no fluid. That's why you can see the cardiophrenic and the costophrenic angle, because there is no fluid there, no fluid here, no fluid here. But here you can't even see it. It is obliterated. So number three, you can't see cardiophrenic angle, you can't see costophrenic angle. So there's obliteration of cardiophrenic and costophrenic angles. So this is an image of a left-sided pleural effusion. Left-sided pleural effusion. For these three reasons, we demonstrate. So let's proceed to see the next image. Okay. Okay. Okay, this we have to clear our Okay. Sorry. Okay, let's proceed to the next image. Now, if you look at this image before I proceed, you should know that look at this lung. And if you look at this, the difference here you will find that here you have lung markings. This whitish radio-opaque shadows, they are lung markings. And here you see absence of lung marking. It means there is no lung tissue here. You can see it's just clear radiolucent. You can see anterior rib, you can see posterior rib. Okay? It means there is no lung tissue there. That means that lung has collapsed. Okay, so this is not a typical image. Okay, but I want you to notice something. Look at the mediastinal. It is shifting to the contralateral side. So if it is lung, hello. So if it's a lung that collapsed, what is supposed to happen is movement of the lungs. The normal will move to the affected side, because if this collapse, pressure will be more here and it is moving to this side. But what do you think? I want somebody to answer this question. Okay? Who can unmute his mic and answer this question? From what we have just discussed, if you really understood all what we've discussed, somebody should answer what pathology is here. Yes? Aisha SM. Aisha SM. Unmute your mic and answer. Aisha SM is not in the class. Okay. Dr. Mary, I hope you take a snapshot of our attendance. Let's see those that are not here. Aisha Muhammad. Okay.
Doctor.
Aisha Muhammad, you are. So, are you with us?
Yes, doctor, I'm with you guys.
So, Aisha Muhammad, what do you think is wrong with this patient? From all what we discussed, if you look at this image clearly, what do you think is wrong with this patient?
Honestly,
yes, attempts. I'm not saying you must get it right. Aisha Muhammad.
maybe tension pneumothorax.
Why do you say tension pneumothorax?
Because there's a mediastinal shift.
Mediastinal shift.
I honestly, yeah.
I can't hear you.
Yeah, because there is a mediastinal shift.
Where?
To the normal. one affected part.
Please speak clearly so that we get you.
Maybe
Okay.
it's the network.
Okay,
I
Aminu.
think my network.
We can't hear Aisha Muhammad. Aminu. Yes, Aminu, can you tell us? Can you unmute yourself and answer?
Yes, sir.
What do you think is wrong with this patient?
I think too, sir, tension pneumothorax,
Why do you say tension in the thorax?
because there is a mediastinal shift to the opposite side, to the left side.
Okay, to the contralateral side. There's the right side. This is not the left. This is left, this is right. I mean,
Okay, sorry, sir.
what again?
Because of the mediastinal shift to the left side.
I said this is not left. Are you hungry? This is right. This is
Sorry, right side.
right. This is
Right
left.
side. Sorry. I want to say right side here. Sorry.
What again?
There's also a depression of the diaphragm on the
No,
affected
I'm
side.
asking Aminu. I don't want a random answers. Aminu don't know. Yes, Aisha SM is not with us. Amra Sali. Is it Amra Sali? Who is this? Unmute yourself and answer. Okay, this person is not in the class. Who is D Real? Yes, who is D Real? It's not also in the class. You see, people are not participating at all. I'm just here wasting my time. MM.
Okay.
Yes, what do you think is wrong with this patient?
We'll go with the other sensations of pneumothorax.
Okay, you are not in the class. We can't hear you. What do you think is wrong with the patient?
Hello, sir, can you hear me?
Okay, Hafsat Idris. Hafsat Idris.
Hello?
Where is Hafsat Idris? You know, when we were giving lectures, she was even making noise in a noisy background. We have to mute her. Hafsat Idris, what do you think is wrong with this image?
Hello, sir.
Yes, what do you think is wrong with this image, this patient?
Sorry, I couldn't get that.
Can you see the screen? Can you see the screen? Hafsat, are you there? Okay, she was not paying attention. When we were discussing it, she was in a noisy background.
Hello?
Okay, Halima. Halima,
Yes, sir.
what do you think is wrong with this patient?
Sir, I think it's a tension pneumothorax
Why do you think it's a tension in the thorax?
because the diaphragm on the affected side is moving downward, and then there is a mediastinal shift to the right side,
Contralateral side too.
contralateral side, and then I think there are fractured anterior ribs. I'm not sure.
No, what are the features of tension pneumothorax? You look for them.
Okay.
You mentioned two, you have one more. I told you there is a triad you look for on an X-ray. Okay? So, okay, you've
Okay,
missed that.
widen intercostal space.
Yes, you
Include
have.
intercostal space.
Look at this intercostal space here and this intercostal space here. They are not the same. This one is wider than this other one. Okay, so this image has classical features of tension pneumothorax. One, there's depression of the diaphragm of the affected side. Two, the mediastinum shifts to the contralateral side. And three, there's widening of the intercostal space. Those are the features of tension pneumothorax. Okay. So I think you guys should be paying attention to what is being discussed. Okay, let's proceed. Okay. Okay. I think I'll ask another candidate to tell us about this. Yes, who want to attempt? Yes, who wants to attempt this?
So this is a case of left-sided pneumothorax as well.
Left-sided pneumothorax. What are your reasons?
Okay. So you can see lots of long markings on the left side. You can see the contralateral shift of the trachea.
Okay.
And there's also widening of the intercostal spaces
Where?
on the left side.
Yes, but do you notice that this widening is not remarkably different? They are equal. And if you look at the diaphragm, they are fairly at the same level. So it's
Lovely.
not a tension pneumothorax, it's just pneumothorax.
Yes.
Yes, so you are right. Now, don't forget, in tension pneumothorax, you have three features. For this X-ray, you have only two, and the diaphragm are at the same level. So it's just a left-sided pneumothorax. That is very good. Yes, who wants to attempt this? This is an image from your previous exams, this particular image you are seeing. It's an image from your previous exams. Who wants to attempt this? Where is Tariq?
Huh?
Tariq, are you with us?
Yes, I'm with you.
So attempt this.
All right. This okay, hold on a sec. Okay, this is from the back. So this is a left-sided tension pneumothorax.
Is it
Yeah.
left?
No, it's left. It's left.
Where is left? This or what is this? Is this left or right? Which one?
Left. Honestly, left. Oh, sorry. No, this is right, actually. Sorry, this is right. It's right-sided tension pneumothorax.
Right-sided tension pneumothorax. What are your reasons?
So there is abscess of long markings.
One, yes.
Okay. The widened, the intercostal space is wide, but not really noticeable, but it's there. And there is,
Intercostal space, yes. What again?
there is this stuff, what's the name of it called? Mediastinal field to the left side.
Yes, mediastinal right side. I don't know why you do. So when you see X-ray, Since you don't know how to differentiate right and left, your right side is the left. This is
Okay.
the right. Okay.
Okay. Thank
What is
you.
the third feature? You are not finished. Not thank me, my friend. What is the last feature?
There's also hyperfluency of the lung, absence of lung markings.
No. You people are not following at all. The third feature is depression of the diaphragm at the affected side. Don't you see this diaphragm is lower than the diaphragm here?
Yes, sir.
You see me repeating this thing again and again. It's something that comes out almost always in the exams. Tension pneumothorax. I've talked about their presentation. Don't forget these three features on an X-ray, okay? Okay. Now, how is tension pneumothorax treated? After this, I think we are going to stop here. How do you treat tension pneumothorax? Who wants to attempt? Yes, who is Kingsley? Kingsley, are you with us or you are just unmute yourself? Kingsley. See, Kingsley is not in the class. He just logged in.
Insertion of drainage tube in the second.
Are you Kingsley?
Oh.
You see, Kingsley is not in class. Lukman.
Yes, sir.
How do you treat tension pneumothorax?
I don't know how to say it, but I think you just puncture the lungs small so that the air will go out.
No, that is wrong. How will you puncture the lungs that is already punctured? Yes, you want to cause more trauma, you puncture the lungs. Zakaria Nuruddin. Where is Zakaria Nuruddin? It's not here. Najat Sani. Najat Sani.
Sir?
How do
Yes,
you
sir.
treat pneumothorax?
Tension. Given antibiotics.
Of course, when you do antibiotics, after you administer, you just pack the patient and take him to the mortuary. Najatu.
Yes, sir.
After giving antibiotics, just do last office for the patient and take him to the mortuary. You hear that, Ba? Jamilu Kabiru. Jamilu Kabiru. Where's Jamil Kabiru? He too is not in class. You see, all of you are not even here. Nusaiba.
Again?
Yes, sir, I'm here.
Nusaiba.
Sir, I think the only thing we can do is firstly we did medial decompression.
Yes, what do you say? How do
medial
you
decompression by inserting a large bulb needle, but I don't know. I'm not sure.
Okay. Now, you should, when a patient presents with features of tension pneumothorax, you pass a wide bore cannula. Okay? A wide bore cannula, size 14 or 16, those are wide bore cannula, at the second intercostal space of the affair. I hope you are all listening. Anybody that fails these cannot be a medical doctor. You pass because the patient dies in minutes, within 4 minutes, that patient is dead. You pass a wide bore cannula, either size 14 or 16, at the second intercostal space of the affected side, at the mid-clavicular line. You will hear a hissing sound signifying a gush of air out of that pleural space. This is thoracostomy. You do what is called a needle thoracostomy by inserting a wide bore cannula at the second intercostal space, mid-clavicular line. That is the first emergency treatment that is done to save the life of that patient. Okay, so we are going to stop here. Okay, I think you have to go and review all these things we discussed. I'm going to share, if you've not paid attention very well to what I'm saying, you still have to watch it again, all what I've been saying. And you have to go and read about some of these things we discussed. So tomorrow morning, you are going to have 100 MCQs by 8:30, and you are going to submit at the appropriate time, and we mark. Then in the afternoon, you go for your group discussion. So thank you. Any question? Any question? Does anybody have any question?
I have a question.
Okay.
Please, I did not get the difference between tension pneumothorax and then pneumothorax, the X-ray features. Yeah, difference.
Okay, the difference between tension pneumothorax and simple pneumothorax.
Yes, sir.
Yes, any other question? That is one good one. Any other question? Difference between tension pneumothorax and simple pneumothorax. That is number one. Yes, any other question? Okay, no any other question. Everybody's clear. I'll take a snapshot of our attendance before we leave this place. And before the snapshot, everybody must answer his name. Now, in tension pneumothorax, of course, when you see an X-ray with a collapsed lung on an affected site, you see radiolucency. Then you now look for three other features. One, there's mediastinal shift to the contralateral side. Two, there's widening of intercostal space. And three, there's depression of the diaphragm. In simple pneumothorax, when you see a radiolucency, okay, it doesn't have mediastinal shift, except when the pressure has built enough to cause mediastinal shift. That is when you see mediastinal shift and depression of the diaphragm of that affected site. All these features, these three features, are seen in tension pneumothorax. You just see radiolucency and reduction of the lung size. When you look at the vascular marking, there are reduction in the vascular marking, and you see area of radiolucency. Hope that is clear.
Yes, sir.
Okay. So let's see who and who are at the beginning to the end of this class. Aisha SM. If you are in this class, you unmute and answer. Aisha SM.
Yes, sir.
Aisha Mohammed.
Yes, doctor.
Aminu.
Yes, sir.
Aisha Sali.
Yes, sir.
Who is this D-Rail? You have to put your name. There is no any registration that is D-Rail. Who is D-Rail? You see, he's an anonymous person and he's not in the class. MM.
Yes, sir.
Is that MM?
Hello. Yes.
Fatima Makinta.
Yes, sir.
Hafsat Idris. Hafsat is Idris.
Yes, sir.
Okay, your background is not noisy again. Halima. Halima is not in class. iPad, who is this
Class.
iPad?
I'm in class, sir.
Okay, who
So
is
it's the network.
Yes, sir.
who is iPad? We don't know who you are.
Zara Hassan.
Zara Hassan. You
Zara Hassan.
better put your name. As far as I'm concerned, you are not
Okay, sir.
it's iPad that is here. Jamil Kabiru.
Yes, I'm here.
So where were you when I was asking you questions?
I was having network issues.
Everybody always blame the network. You just mute yourself and be doing some other